decompression. I will try to quickly talk about, to highlight some of the vital points in this difficult issue. I would like really to start with one word about the corona facts. First of all, our sympathy and heart is with you, Francisco, at Italy. We all pray that Italy returns back to its beautiful shape soon. The whole world is sitting on its knees and praying for this pandemic to finish soon. And we all, as human brothers, we should help each other in doing that. I will talk about learning from our neighbors. We, as wise doctors, supposedly, we should learn from our neighboring doctors. I avoid operating in ophthalmic hospitals, in fact, because when I sit in the operating room with the neurosurgeons, cardiac surgeons, maxillofacial surgeons, I get the chance to talk to them and get some of their wisdom. Some of my neurosurgeon colleagues say that the CP angle, the cerebellopontine angle, and the cavernous sinus are no more neurosurgical specialties. These are interventional radiology specialties now. When you have a CPA angle, cerebellopontine angle lesion, gamma knife is the answer. You should not go operate and kill the patient or give him a morbidity. So from here, I apologize if this is not good for, if somebody doesn't like this, but I feel the medial wall decompression is now getting out of hand to experienced ENT doctors who know very well how to manipulate the medial orbital wall, how to manipulate the medial orbital bone, the periorbita, the sphenoid, the ethmoidal sinuses, and they know how to tackle that area much better than us. Anatomical consideration. The orbit, as you all know, is shaped like a quadrilateral pyramid with its base in plane with the orbital rim. 7 bones, we teach our residents, 7 bones conjoin to form the orbital structures. As you can see, you have to know this very well before trying to touch anything within the orbit. Remember the maxillary bone, the lacrimal, the ethmoidal, the sphenoidal, the frontal, and the zygomatic bone. You have to know where each one of them starts and ends, and how strong each one of them is, to know how to manipulate this area. The orbit is it's a cone which is enclosed like a compartment bounded by a bone and by the septum. This is an orthopedic concept. The orbit has bone all around, and in the front open sky area is the tight septum, which is something it's not a very elastic tissue, so it's a firm tissue. So the orbital contents are very well contained. So this is what brought the idea of orbital decompression. You want to do something to relieve this tightening pressure on the globe and on the orbital contents. You have to take off some of this tight pressure. The theory says that the intact orbital septum can withstand up to 120 millimeter mercury in some cases. If you keep ballooning the orbit with pressure up to 120 millimeter mercury, the septum can still resist, but then it gives way, and then the proptosis starts. By analogy with the pathophysiology process described as the compartment syndrome, as our orthopedic colleagues teach us, there's a closed space, there's nowhere for the contents to go, so they start to squeeze themselves and to kill themselves. We don't want this to happen. So then the idea of decompression came. It's a 100-year-old, it's a century-old idea, the orbital decompression, by removing one of the bones and opening the tight periorbita and allowing the fat to come out and properly removing much of the fat. This way you are relieving the pressure and giving some oxygen to the area. This is the surgical plane. We have the surgical options. As you can see, this diagram showing the areas how to access. Jeffrey Rose, teacher of the whole world, has taught us always and always how to approach the orbit and from each part of the orbit. So if you want to do a medial or orbital wall or a lateral orbital wall or a floor, these are your guidelines. In the past, they used to say that you can do 4 walls decompression, but I think this is an imaginary thing to do orbital roof decompression. I think nobody on this planet is doing this. The main concentration, in fact, is on the lateral orbital wall in yellow, the medial orbital wall in blue, and the floor in orange. This floor area is getting less and less popular. Why? Because medicine, in medical career, we learned that what works will continue and will stay. What doesn't work will go away. The concept of balanced orbital decompression is running the show now. You can do medial orbital wall decompression. Usually you start with it, then followed by a huge lateral wall decompression going back all the way back to the sphenoid and removing all this bone, opening the periorbita, releasing the fat, taking extra fat as much as you can. You have done a beautiful work in this way. No need for anything which gives you problems or gives you unforgiving scars. The patient, how to prepare our patient for decompression. It's not all about exophthalmometry, Hertel's exophthalmometry, imaging, and taking patient to theater. You have to make sure that his hormonal status is controlled. You want to make sure that he is immunologically controlled. By that, what I mean by TSI, the thyroid stimulating immunoglobulin, and his autoantibodies are within normal limits, because this is one of the secrets of failure. My mentor in the US, Dr. David C., will do TGI and TSI for every single patient, and he would never operate on anybody before addressing his immunological problem, usually by giving him the pulse steroid. Smoking plays a very important role in making you a good outcome. If the patient is a smoker, you are talking about bad outcome relatively, or less favorable outcome. Discontinuation of anticoagulation is something unquestionable. Otherwise, you will end up in a catastrophic bleeding, perioperatively and post-operatively. Counseling and consenting preoperatively by letting the patient know what they are heading to, that they might be having a vision-threatening problem, double vision, the problem. The imagination of how much improvement he would have. He has to accept all this and to understand all this before taking him to operating room. The term cosmetic decompression is probably unfair, because every thyroid ophthalmopathy patient has a functional problem in addition to his cosmetic cosmetic disfigurement. So you have to give the right to every person with a severe thyroid ophthalmopathy to get the chance of having his operation done. But remind him that, my dear, I'm sorry, I cannot promise you that you will return as beautiful and pretty as you were. I will do my best to improve things, but I have no guarantees that your eyes will return as pretty and beautiful as they were. In the absence of the optic neuropathy, elective surgery is done to reduce the retrobulbar pressure, and it's usually an elective thing done 3 to 6 months following the hormonal control. My colleague Francisco covered this very beautifully. And we learned a lot from his talk. I will not repeat anything of what he said. Experimentally, the amount of measured orbital pressure release depends significantly on two things. The two main factors, you as a surgeon, if you want to be happy while operating, remember removing one of the walls and opening the periorbita and removing some of the fat. You have done a great job. The patient will feel that tightness has gone. His intraocular pressure will drop. His intraorbital pressure will drop. His proptosis will drop. The more expert you are, the more rewarding your result will be. Only 5% of Graves' disease patients will warrant decompression usually. Usually we resort to decompression, the traditional teaching when you have optic neuropathy, orbital corneal exposure, but the cosmetic indication is definitely increasing and increasing. The concept of balanced decompression, thanks to Dr. Goldberg, who probably was the first person to introduce this back in the 1990s, the concept of balanced decompression, because decompression was always a very super major surgery with super major complications. Mr. Rose, Jeffrey Rose, is a pioneer in lateral orbital wall decompression. He has attracted so much attention to the lateral orbital wall operation as a solution. My mentor also, Dr. Tsi, has done a beautiful work on this, but balanced decompression has made, in my heart, I feel it made a revolution by addressing the medial orbital wall and the lateral orbital wall alone. The medial orbital wall is an endoscopic wall. The lateral orbital wall is an oculoplastic wall. That's how I understand it. An endoscopic approach, when you attend the procedure with a talented and with a qualified ENT doctor, you realize how poor we are doing this transcaruncular approach, going back, avoiding the ethmoidal vessels, trying to clear the sinuses, the ethmoidal sinuses well, all the time looking at the pupils and wondering whether you have done enough work or not. When you watch it with a qualified ENT surgeon, you see the beauty and the speed within which he would go within the nose. He would he will prepare the nose first of all, submucosal dissection. He will reach the lamina papricia, start removing the bone bound back to the sphenoid bone, and then he will clean the sinuses. He will open the periorbita, and you will see the orbital fat, the giant balloons of orbital fat prolapsing and coming and decompressing the globe nicely within 30 minutes from the starting moment of the operation. So you can see now what's going on here. This is he's preparing the nasal cavity, nasal mucosa. I will run my video quickly. I will not take lots of your time. So he will do the submucosal dissection. He will reach the lamina papricia. He will start taking elegantly and confidently the lamina papricia. He will clear his ethmoidal sinuses, sphenoidal sinuses, full of confidence. This is the lamina papricia again I'm showing, and the sinuses being cleared away from his way. Now he's incising the periorbita. you can see the ballooning of the fat all the way. It's coming within the nose. It's playing within the nose. We usually struggle to see this thing. So within 30 minutes from the starting moment, you will your ENT colleague will show you this beautiful thing, the fat from the back from the sphenoid sinus to anterior ethmoidal sinuses. All this nasal cavity is filled with the decompressed fat. What a beautiful thing to see. I will stop this one. I will stop this YouTube here. I will go back to my original presentation. In 2020 is a balanced decompression, medial orbital wall, done elegantly by the NT doctor. The lateral orbital wall done by an oculoplastic surgeon. It should not be done by maxillofacial or by ENT or by anybody else. So skin crease incision, hidden incision. You go down to the bone and you reach the periorbita. You dissect the temporalis off. Your bone from inside also is exposed, and you remove the whole orbital bone, lateral orbital wall. You keep the rim, as you can see in this. You keep the rim, and usually we used to struggle with the saw, my friends, with the saw and the drill. Now they have these ENT doctors. They have these micro drillers. They just perforate the bone like within seconds. You don't need to do all this saw business and worrying and frightening work. With the saw, you just perforate and start widening your decompression and reach back, all the way back, but be cautious. Remember the lateral orbital wall, thick, thin, thick, thin. This is the anatomy. In this area, you have to be. Yes.
Can you share, like, do a presentation and put on the slide you want to? Yes, now we can see it. Can you just make presentation so that we can see it in our screen?
Okay. In this area, you don't have to be brave. Your dura is here. Your CSF is here. You have to be cautious. Go all the way back. Decompress, but don't be that brave in this area. The old surgeons, they used to do this beautiful small bicoronal flap, which is a terrifying thing, which should not take place anymore in our life, I hope. So the message for me to take home from my talk is that orbital decompression now is the balanced decompression. Medial and lateral walls, and floor in occasional cases. You might disagree with me, but I felt it made our life so simpler, the recovery much faster, the morbidity much less. Patient won't stay just overnight in the hospital. We place a drain inside, and second morning he'll be in perfectly good shape. This is my point of view. The people might disagree, but I hope I will hear some feedback about this.
No, we agree. Thank you, Dr. Samer. You have given us an overall picture of the orbital decompression. The orbital decompression